minutes to an hour?
Estimated or anticipated critical events, for me it's mainly hypotension.
Yeah, and I guess we could potentially kink off the portal vein and cause acute portal hypertension, but unlikely.
Blood products are, we believe, next door, although I didn't explicitly ask.
Yeah.
I'm using noradrenaline rather than terbutamine and dopamine, but they are available. The emergency drug response sheet and IV fluid boluses are all calculated and or in my head. Swab count is 5 large swabs. Do you
Yes.
need any imaging?
I do not.
I don't have any particular additional concerns beyond hypothermia. Do you
Okay.
have any other concerns?
Nope.
We're attached with our monitoring. I don't need a Doppler. Antibiotics are being given post 125 amoxiclav twice daily for 2 weeks. And I believe the dexamethasone anesthesia is appropriate, although I'm not 100% sure.
All right, well, it started cutting, and so, and there's no movement or twitching or anything. Hi guys, this is Charles. I'm one of the surgeons at Melbourne Vet Specialist Center. Today we're operating on little Charlie. Charlie is a 4-year-old dachshund who presented with a history of gastrointestinal signs and had an incidental finding of a large portosystemic shunt. It's a portoazygous shunt. And Charlie was basically asymptomatic up until this point. Bile acids were found to be markedly elevated, and a large shunt was found on CT. Since management of the gastrointestinal signs, with supportive care, and we have been administering lactulose, he's completely back, or she's completely back to normal. This was not an easy decision about whether to go to surgery, because our general impression is that dogs that have portosystemic shunts are going to live longer with surgical repair. We do have a little hernia here from the previous ovarian hysterectomy. Are going to live longer, but the risk of postoperative seizures is higher in dogs that are older. So we had quite an involved discussion with the owners, and they went away to think about it, and collectively we decided that the best thing for Charlie was to go ahead and repair this shunt. And so the way that we're repairing it is to put on an amyloid constrictor. Incidentally, Charlie also has some stones in the bladder, which we're going to retrieve at the same time. Now, Charlie has been spayed, and so we have to be careful for adhesions to the underside of the linea incision. Bleeder there in the falciform. And if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications. So we'll do the portosystemic shunt first, because that's the more critical part of the procedure. And then if everything's going well, we'll go and retrieve the stones from the bladder. So I'm doing a nice long incision. to make sure that we've got good visualization, although we've already had a CT scan on this dog. Now, other than identifying the shunt in the bladder, I am not going to do a complete exploratory because we do have the CT scan, and in addition, I'm trying to get this dog off the table as quickly as I can.
Is this the same type of shunt commonly found in can areas?
Well, can terriers get extrahepatic shunts, and so this would be the same in that regard. I wasn't aware that there was a specific breed predisposition to Porter azygous shunts, but if that's something that has been identified in the past, then yes, this would be that kind of shunt. Otherwise, it's just Porter azygous shunt, which, again, I wasn't aware that there was a specific breed predilection, but I'm happy to stand corrected on that. Let's get our Balfours in there. Let's get our guts out of the way. Our liver is small in this dog. Can I get a larger Balfour, please? Thank you. Gallbladder is huge. It's soft, but very large. And then we'll get our spoon. I wonder if I can use a smaller spoon. Yes, I can. Alright, so we'll have a quick look dorsal. So we'll come in on the side here and see if it's obvious. That side, so I see the vena cava. Alright, so I'm going to have to go through the greater leaf of the omentum. Tear a little hole in that because often that's the best view of the shunt. So that's it right now. That's spleen. And that's stomach. Might pull our spleen out. Look from the other side here. I have reviewed the CT scan recently, and it's kind of right at the hilus of the liver. Right up in here. I apologize if my head's in the way. As I always say, if only one of us can see, it probably should be me. So that's the shunt right there. And you want to put the constrictor on the shunt as far cranial as you can. What we might do, can I get a malleable retractor, please? I'm going to put that retractor in there, but we have to be really careful not to put too much pressure. So I'll have you put your fingers in there. Try. Okay, so let's get this. pull that cranial there and just kind of try to gently retract down here. Let's see if I can zoom in a bit. So that'll be the shunt right there. Can I get the, let me have a look at the amyloid constrictors, please. And this is quite a delicate part of the surgery.
That one you said you wanted.
That's the one I want, yeah. Quite delicate because if we tear that shunt, we're in big trouble. Thank you. So I have the constrictor here. So I have to pull the little, or push the little key out first and not lose the little key. All right, and then carefully dissect. Gotten all the way around the shunt there. And then I need to just hook the shunt with the constrictor. Usually the way I do it is I open my forceps and drop the constrictor around the shunt like that. And then I'll pull out my right angle. So now the constrictor is around the shunt. And then I have to get my little key. And drop it in, but it can be tricky. And if you drop the key and it's loose somewhere in the abdomen, that can be quite frustrating.
So why don't you use the cellophane band, Charles?
So, great question. I have used the cellophane band several times, but more recent literature suggests that you're going to get better occlusion, more consistent occlusion of the shunt using the hemorrhoid constrictor. So that's in place. I'm really happy with that. So we're finished with that part of the procedure. So we can take this out.
They're better anaesthetics with the constrictors or the coils than cellophane bands as well.
Better anesthetics. Why is that?
Just because of you've got instrument pressure to a degree, and because it's all manual, you're more likely to get portal hypertension.
Right. So our anesthetist is saying that because the procedure is manual with the cellophane band and it's more subjective, you're more likely to get portal hypertension. Can I get some 4O PDS, please?
Personal experience, not sure if that's in the literature. I like the constrictors and the foils.
Can you please write a 4-knot PDS for me, Georgie? Thank you.
And extend my incision a little bit farther caudally. Doing the constrictor first in the surgery is also nice because it means that we'll have more time to observe for problems with the portal hypertension. All right, so we've got our urinary bladder there. Putting in the stay suture. Once we retract our urinary bladder cranially, we'll get some moisten lap sponges and just protect the... hold on just a second. Release that, please.
In the Netherlands, there's a predisposition to portosystemic shunting in can terriers that necessitates screening prior to use as pedigree breeding animals.
Right, but not specifically portoizygous shunts.
This is portosystemic.
Portosystemic, right. Yes, this in that case, yes, this is the same kind of shunt that can terriers get. All right, so now we'll put in a couple of other little stay sutures just in the bladder wall to retract that open for me. Pull that toward you, Jacob. Just the last stay suture toward you. Managed to tie a knot in my suture material. Millie, can I get a spoon, please?
Sorry?
A spoon?
Oh, yep.
Just drop that on my side. Let's get suction turned on, please. And that can go right down in the hatch. That's great, thank you. Now, from the viewers watching, can you tell me what kind of stones these are likely to be, or might be, because of the diagnosis of a portosystemic shunt? What kind of stones are these likely to be? There now. Again, waiting to hear what kind of stones are these likely to be.
No one's putting their head on the cutting block. Oh, ammonium irate, maybe that would say nitrate from taste.
Ammonium biurate. And that is exactly right.
You're right. I like the ammonium irate.
These are very likely to be ammonium biurate crystals because of altered metabolism. that happens in dogs with portosystemic shunt.
A lot of people are correcting us to urate.
Yeah. We'll give, was it Kate? We'll give Kate the credit on that one.
Yeah.
There's no points off for spelling. Can I get an 8 French urinary catheter, please?
Stiff?
Yeah, that's fine. All right, so we just have a look down into the bladder. Just, get some suction in there. And these are actually small enough that you could hydropulse them. Thank you. Let's get some flush, please. Go ahead and grab some flush. Can I get a syringe, and maybe a 20 ml syringe? Yeah, go ahead and flush.
I will have to do that.
I remember it primarily because it was on my surgery board oral exam. I would have remembered it anyway. But a really good flush in there. Have a quick look. Put some right down into the trigon. We're all clear. Right, so we just retract on that one for me, please. Okay, and then I'm just going to flush. So go ahead and pass that. So keep tension on that. So we're just flushing anything that's in the urethra. And again, these are pretty small, smooth stones, so I don't know why they haven't passed, but if there were any residuals, we could probably do hydropolitan on them. Can I please get some more 4O PDS? And just have one last look. And we're all clear.
Are we sending the stones away now?
Yes, we are. They'll just go to Hills. Can I get the suction turned off? So now we'll close the bladder, and I like to do a 2-layer closure. I know you don't have to. Give me a little bit more traction on both.
Is it okay if I turn the aircon down a little bit
Yeah?
for the dog? Is it okay?
Thanks, Nelly. I'll require one of your surgery gowns post, the cleaner of the two, and I'm going to make a little makeshift
Hot
igloo
box.
using it. That's right. For incubator.
And again, a 1-layer closure is perfectly acceptable. I have had a few bladders leak after surgery, and so I am a bit anal about doing a 2-layer closure. simple continuous is fine. And it seems like if you're going to have a leak, it's going to be at the apex, at the end up here. So as far as leakage of urine in the abdomen, we are going to lavage out the abdomen. It's not a big deal. There's a minor amount of urine leakage. Urine is sterile for the most part. So this is the mucosa and muscularis that I'm closing.
You just answered about urine in the abdominal cavity.
Yes, I have.
Really? I don't think I'm missing anything.
Oh, it's fine. I think I have most of the other stuff. It's just. Fentanyl?
Do you want me to, it's already on the other sheet. Okay, now I use 2 bars. Just drag. Yes, that's true. Is the suture going through mucosa?
Yes, the suture does go into the lumen. I avoid knots in the lumen on the bladder, but suture into the lumen is fine.
Does the presence of urine change the tensile pathway?
Yeah, so there's some controversial studies, or conflicting studies, I guess, out there regarding the use of PDS in the urine. When I studied for my boards, it was very clear that PDS was the one that lasted the longest in the urinary bladder, in a urine medium, but there have been some other studies that suggest that maybe you have premature breakdown. I am not aware of any clinical cases that I've had that have leaked weeks after the procedure. If you're going to have a leak, usually it's within a day or two, and that couldn't be because of premature breakdown of the urine.
And mucosal structures tend to heal very quickly, don't they?
Yeah. So there's just a comment from Georgia, our anesthetist, that mucosal structures tend to heal very quickly. So urinary bladder is one of the fastest healing structures in the body.
Oh, cool. There is a comment, nylon is calculogenic.
So there is a comment, I don't know if you guys heard that nylon is calculogenic, meaning that it supports the formation of stones. I probably tend not to use a non-absorbable suture in the bladder wall. And this one I'm going to use a Cushing suture pattern. Just making sure that I've gotten to the end of my incision. I have. Cushing suture pattern inverts a little bit, and the thought is that it may provide a better seal. So I'm just going through muscularis and serosa. these two stay sutures.
Any reasons not to use diathermy for bladder entry?
So diathermy, electric cautery, question is there any reason not to use it to enter the bladder? I would be pretty concerned about that because you are going to get some tissue necrosis with electric cautery, and I would not want to get tissue necrosis beyond what I can see. Which might predispose them to leaking after surgery.
And we've just got a clarifying question to confirm that you are using PDS.
I am using PDS.
I feel like I'm hosting a little webinar for you.
My MC, Master of Ceremonies, is Georgie, our fabulous specialist anesthesiologist. Okay. All right, so then I'm just going to get hemostat and just try to poke into the bladder. Is that a small one? Yep. So I'm just going to probe my incision.
And a question, are you using 3-0?
I'm using 4-0 PDS. A little area there that might just oversew that. I'm sure it's fine, but I'm a bit paranoid. So the probe couldn't get all the way into the lumen, but it poked in a little bit. So I'll do just a little simple continuous on top of that. Can I get some 2O PDS, please?
Yeah, I think they're pretty good. Excellent. 2-0?
Yes, please.
They would have only just done it. 2-0 PDS.
Thank you. I'm sure that this extra suture layer was overkill, but I'd rather that than the opposite, which is having it leak. Can I get some warm saline, please?
Yes.
I'm going to cut that out of the stay suture. I just cut it.
Where do you want me to put it? You've got, your bowl is...
That's all right, that's warm still.
Enough?
Yeah. Might need some more, but
The bottle still is holding some temperature.
great. All right, so get our extra towel clamps here.
Can a new grad do this procedure?
This is not something that I would typically associate with a new grad procedure, just because you want to be fairly quick and you want to be really comfortable with your soft tissue handling and such. But if you got to the point within a year or two that you were very confident with your soft tissue surgery, do you see the other towel clamp here? Or is that the one that I dropped?
I think could we get one more?
That's all right, we're good. So just lift up on that. Can we get suction turned on, please?
Yep. And there was a question about the camera positioning. Finding it hard to orient.
So I will try to get you oriented in just a minute. And the guts are all looking really nice and healthy and pink. If we had portal hypertension, those would take on a dusky gray appearance. And I'd have to go back and reassess and potentially remove my constrictor. And making chromosomes up here.
What type of stricture pattern could you use if the bladder wall is thickened?
You can still use the same. You can still use that same suture pattern. If you had a really thickened bladder wall, I might be more likely to do a simple continuous suture pattern or simple interrupted suture pattern, Singer layer. What happened to that 2.0 PDS? That's it.
There's a conspiracy theory that the camera is on the opposite side to where you normally are. But the camera's on the normal side. Do you normally stand when the animal's on the side?
No, so I'm always on the right side. The camera is at the foot of the table, so closest to the caudal end of the dog. And I positioned it intentionally so that my head would be out of the way as much as I could.
And can this recording be viewed on demand?
Yeah, so this will just be on YouTube on both Vet Dojo and Vet Align, and it can be viewed anytime. And I believe that Charlie's owners are watching live. We got them set up on the video stream. So if you guys are watching, everything's gone well, as you can see, with the surgery. And I'll give you a call in a few minutes when I'm out of the theater.
I don't know if you'll know this because we practice in Australia, but how much does a shunt surgery cost in the United States and how much does an aneroid constrictor cost?
So in the U.S., well, we estimated 7 to 7.5. Can I have suction turned off, please? We quoted 7.5 to the owners, Australian dollars. In the U.S., it would probably be similar, maybe slightly more. The aneroid constrictor costs us about $250 Australian, and then with the markup, it's probably $650 to $750 to the owners.
Would you normally get like 2 or 3 sizes, like preempting this sort of case? Or?
Yeah, so you ought to have a few different sizes in stock before you attempt this kind of surgery, because you don't know exactly what you're going to need. And I think they go something like 3, 5, 6.5, 8 mil, something like that. Most of the ones I use are going to be the 5 mil.
Do Given that most of them are like small breed dogs for extra height.
Yeah. In large breed dogs with intrahepatic shunts, those shunts can be a centimeter, centimeter and a half in diameter. And some people still dissect through the liver to identify the shunt and to occlude them. I now just do exclusively coiling, transvenous coiling, so we do the whole procedure through the jugular vein. And I do have a couple of videos of that on Vet Dojo YouTube channel. Really interesting, but it's all done fluoroscopically. I do not oversew the median ligament of the bladder over the incision or over the cystotomy.
With the bupivacaine, we can use up to 3 mils.
Yep.
Jacob, don't forget,
3 mils, yep.
please.
We're doing that in the skin or in the linea?
Once you've closed, it can be put into the peri-incisional muscle.
Okay.
Get a 20. Would you prefer a 25 gauge needle, Jacob?
Yeah, long 25 would be ideal.
Yeah.
Thank you.
Keep assuming Jacob will do it. Jacob or Charles?
Jacob will do it.
So short 25.
That'll be fine.
Yeah.
Let's make sure that I've got no hernia here. All right, so I'm going to go ahead and wrap up the live stream. Get some 3.0 PDS for Jacob. If you haven't already done so, please subscribe to our channel. And so there's a comment here, 8 to 10K in the US. I think that's probably fair. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. Just going back and making sure I haven't missed anything. Just going through, making sure that I haven't missed any questions. All right, so I'll go ahead and wrap that up. Again, if you haven't already done so, please subscribe to our channel, and we will see you again soon.
Not recording anymore?
Nope.
Next time I'm putting an outline in.